Hello and welcome to another episode of our oncology podcast series, Onc Now, with me, your host, Dr. Jonathan Sackier. This series was designed to spotlight the leading experts in all subspecialties of oncology, and today I'm delighted to be joined by Dr. Alexander Spira. Alexander obtained his bachelor's degree in chemistry at Harvard, followed by his medical degree at New York University and a PhD at the same institution. Dr. Spira is a medical oncologist with Virginia Cancer Specialists and serves as the CEO of Next Oncology Virginia. Beyond his professional accomplishments, he cherishes spending time with his family and shares a love for travel with his wife, taking a trip abroad every year. He's also a passionate American sports fan, enjoying baseball and football games with his sons, as well as Cosmo, his beloved golden retriever, who he affectionately considers his fourth son. Not sure if he actually goes to the sports games, though. So welcome to the podcast, Dr. Alexander Spira. It's a real pleasure to have you. So let's head over there right now. So, Dr. Alexander Spira, great to have you with us here today.
Thank you for having me.
Do you go by Alex?
Yes.
Yeah, fabulous. So you told me that you're a New Yorker through and through, living in the Old Dominion, the Commonwealth of Virginia. So New York, food, bagels, pizza, and the New York Mets, for those interested in the American sports world. Many from the Empire State see no reason to travel. In fact, I know some Manhattanites who never leave. They'd say, I'd never leave. Why would I leave the island? Best place in the world. But you do. What's your most memorable adventure that you've had during your family travels? And is there a destination that's still on your bucket?
I'm a huge history buff, so I love going to Europe. I've been to Europe a couple times. We're going to try and go back again. I mean, it's amazing. I use the analogy that, in New York, St. Patrick's Cathedral was built in the late 1800s, and that's old, and everybody's amazed. And you go to Italy, and, 100-year-old cathedrals like, they're a dime a dozen. It's really amazing. Plus, obviously, a lot of history, good and bad. So that's what I really love. I think on my bucket list, I want to go to the Galapagos. Completely different than what I've just mentioned, but just cool to see, right? When else are you going to see something like that?
Yeah, off the coast of Ecuador. Yeah, I've always wanted to go there myself. It's on my list. So anyway, I always like origin stories. Well, what took you into oncology? Often doctors are inspired by to follow a given course because of a family issue or someone in their family who inspired them. You one of your mentors was David Ettinger at Hopkins, very famous place, of course, and a famous chap, bit of a legend. What inspired you? What took you into oncology?
For me, the science. I mean, the science is truly amazing. The science about oncology and the molecular biology. And, when I first started, it all sounded really cool, but we knew nothing about it. We knew something about it. We just couldn't do anything about it. But then all of a sudden, drugs that target all these molecular aberrations came by, and the reality finally caught up with what the science was. So for me, it was all about the science about it, which was truly amazing.
Right. So we're going to dig in, and we'll start with lung cancer. You've recently published 3 papers in lung cancer, one on EGFR mutant advanced non-small cell, one, the phase 2 NeoCOAST platform trial, and the other, the Chrysalis trial. Can you tell us about those 3 and what your hopes are for such developments impacting patients living with a diagnosis of lung cancer?
Yeah, so EGFR mutated, we'll start with that, is the Chrysalis is very important because EGFR mutations, really the molecular biology of lung cancer, have become very, of course, very interesting and very treatable, but we need to do better. Right? I mean, we talk about patients with EGFR mutations have targeted therapies, but the problem is at best, the survival is still a couple of years. So we want to be doing better, and things like Chrysalis is clearly where we want to make some headway in finding new combinations, either de novo in first line, and there's a study called Mariposa, as well as in the second line called Mariposa 2. A lot of subtle differences there about whether or not where you give some of these newer medicines, but the fact that we have newer medicines is clearly a step forward for our patients. And there's a lot of other newer ones coming about. NeoCOAST, and there's actually one, it's like a movie, NeoCOAST 2, also coming out in study right now. There, the idea is we take somebody who has early stage lung cancer, and the curability of early stage lung cancer is good, not great. Depending on the stage, it's 30 to 60. We've clearly moved the dial forward by giving patients neoadjuvant immunotherapy, which of course now is the standard based upon numerous studies. But again, we still need to do better. We've improved outcomes by about 10 to 20%. But we still need to do a little bit better. So that's what the whole idea about NeoCOAST 2 is, about introducing newer drugs in the preoperative setting, which we hope to improve curability now. We're not talking about stage 4. We're talking about improving curability. But it's also a good way to test drugs, because not only do you give these drugs preoperatively, but you're being able to see what happens to the tumor specimen by itself, because you're getting a large sampling of the tumor, which we almost never get. So you could look at some of the biology. So to me, those are the big things that I'm excited to look at.
Yeah, very much so. Well, again, in my professional lifetime, oncology has changed dramatically. As a surgeon, I was often looking after colorectal cancer, and that'll be my next topic. But the tools you had available to you have changed dramatically. So you published on real-world treatment patterns and clinical outcomes for chemotherapy-based regime in colorectal cancer. Can you summarize that for us?
Yeah. So one of the things, so we're part of a community-based practice. We're in the DC area, in Northern Virginia Cancer Specialists. So that I spend most of my time doing trials and research. We're still a large community-based practice, which is very different than the classic academic model. And that's important really because a lot of drugs make it through clinical study, but the reality is that those are a very self-selected population, not what real-world patients are. So what we were able to provide is to look at some data and look at real-world outcomes that helps us not only in getting drugs approved, but also, well, with all respect to my colleagues, you're getting rid of what I call the MD Anderson effect. Patients that enroll in clinical studies at MD Anderson have to be a hell of a lot healthier because they were able to fly to MD Anderson. And that's just very different than what real world population is. And that's important. We're really moving away in 2025 just because of efficacy, but we're looking at a combination of efficacy and tolerability, which of course is very, very important.
Yeah. So we're going to get on to the so-called town gown in a second, because it always fascinated me. But staying with some publications, you looked recently at the impact of gender and mutational differences in hormone receptor expressing non-small cell lung cancer. Can you talk to us about this? But first, the word gender, maybe I'm a little bit older. It confuses me. Sex or gender, and what are we learning about the influence of sex on different cancers?
Well, we're learning more. This is more about gender. So, I would say more in the gender and what people are born as, being very mindful of what that means today. But it's really looking at gender at birth and how that impacts. And we clearly know there are different mutations that arise in male versus female at birth. And it's very important as we think about this and we try and target our populations accordingly. It also is very important because those patients can react very differently over time. And this is, EGFR, ALK. Very commonly, we know that there are clear gender differences in those patients and also in terms of how they respond over time.
Yeah. So, well, let's switch topic. My understanding is that KRAS plays a role in cell signaling and that mutations in the gene are found in many cancers, but the protein was deemed to be undruggable due to its characteristics. But I believe there's a pocket in its structure that's led to the development of several inhibitors targeting the G12C mutation. Two of these, completely unpronounceable to me as a surgeon, sotatercept and adagrasib. I can't pronounce these drugs. I don't know what it is. They've been approved in advanced non-small cell lung cancer, and others are currently being tested in clinical trials. You've got a number of publications about KRAS. Bring us up to speed on this science.
Yeah. So first, the easy way to remember, it's either sotorasib or adagrasib. We don't want surgeons to say it because then we'd be out of a job. And remember, there's a RAS right in the middle of it, so that may help you think about it, right? There's the RAS, which is the protein it targets, right in the middle of the names. So right now, we have two approved drugs for second line, sotorasib and adagrasib. So these are patients that have already been treated in the second line setting for KRAS G12C. And there's two aspects we're thinking about, right? Three aspects, actually, maybe more as well, if I really thought about it. So one is these drugs are good, but they're not perfect. They work for an average of months, and we want to be doing better. So there's currently a new generation of drugs. These are drugs that typically bind the KRAS G12C protein And again, this could not be done without the modern age of computer modeling to bind in these pockets that could never really be targeted before. But these are what's called off inhibitors. And there's many off inhibitors. I think I lost track. There's like 6 right now. But we're trying to make on inhibitors, which bind the RAS G12C protein in the active state. And these may be better. So we're hoping that we can make better drugs that target G12C right now. Secondly, we're trying to bring all these drugs into the newly diagnosed patient population. So we think that the patients will be a little bit healthier, newly diagnosed. And again, this is how drugs are approved. They're approved in the second line. And then, of course, we try to move them up in the front line or earlier line setting, here front line, and possibly combining with either checkpoint inhibitors or chemotherapy or both. And those are being done right now as well. And we're hopeful that we're going to get some better outcomes treating patients earlier on. It's complicated because you have to look at different PDL states. Not all these drugs can be combined with a checkpoint inhibitor. Not all these drugs can be easily combined with chemotherapy, but many can. But now we're doing randomized studies of many of these in the newly diagnosed patient to see if we can make better outcomes.
Right.
More importantly, though, we now have drugs that are in clinical study that can target other KRAS mutations. There's a drug, and I'm not going to try and get the names right for this podcast. There's drugs that target KRAS G12D. There's drugs that target pan-RAS inhibitors, and there's ones that target G12V that have not yet hit a clinical study that have clearly shown evidence of activity as well. So we're going to be able to get beyond just C and hopefully target multiple KRAS mutations. And to remind you, if we're just talking about lung cancer, KRAS G12D, where there's clearly drugs that have shown activity, target about 1% of patients. But KRAS mutations in general make up about 40% of lung cancer patients. So the potential patient benefit here is huge if you can get to these more generic KRAS drugs as well as allele specific. There's a lot of subtle differences as we think about the drug development, but clearly is very exciting. So much more to come as all these other drugs are in clinical study. We'll try to move the C drugs up front and get other KRAS drugs approved as well.
Exciting times. So you sit on the United States Oncology National Policy Board and various other organizational bodies. Talk to us a little bit about leveraging leadership positions and instituting steps to accelerate the route to market for new diagnostic modalities or therapies. You mentioned computing power. Undoubtedly, generative AI is going to have an impact on drug development, clinical trial deployment, personalized medicine, so on and so forth. Talk to us a little about new diagnostic modalities or therapies and how we pay for them. Floor is yours. Yeah, you can take this wherever you want, Alex.
Yeah, so I'm part of the US Oncology National Policy Board Executive Committee. And what that is, it's the physician-led board. And to remind everybody, 90% of patients in the United States are treated outside of academic medical centers. So we have to be very mindful of what real-world patients are, about what limitations are. I mean, most oncology patients with care in the community means they're not just going to get a specialist that only treats ALK translated non-small cell lung cancer. They may be lucky to get somebody that just gets treated with lung cancer as a specialty. A lot of our patients still get treated as generalists as well. And one of the big things is, how do you get all the information out to our physicians, not just patients, but to physicians, and keep them up to date? It's not that easy a challenge, and it's very, very important. And we'd be remiss to say, well, these patients should all be treated only by experts. That's not the reality. There's not enough physicians or locations or anything in the world. Two is, one of the goals is to be very mindful about the cost of medicine and the cost of healthcare. We've all seen, especially now, what the costs of Medicare and Medicaid and health insurance is. My health insurance in the United States is a gargantuan amount, and it's only going to go up if we don't adequately manage the expenses. Part of that is managing the drug costs, but it's also doing the right testing and getting patients treated the right way and making right diagnoses. And you certainly bought AI. AI is going to clearly affect oncology. There's no doubt, as telling us what are the things that need to be tested for and going through the mounds of data that we have to go through in any given day. And while many of us not like it, we'd be remiss in not doing our patients a service if we didn't use it to the best of our ability. But at the end of the day, it's still very complicated. And real world oncology is where most of our patients are, and that is not going to go away at all. And general oncologists in the community, even specialized oncologists in the community. I don't know everything either, even though I mainly